I'd like to thank Huma and John for the kind invitation. I'm going to continue this opening session by talking about some key developments over the past year which have strengthened our elimination efforts. And here are my disclosures, primarily in viral hepatitis area of research. And so what I'm going to talk about today is that we actually have seen some progress towards elimination despite COVID-19. So I think there's a lot of focus on how COVID-19 has derailed elimination efforts, and it's certainly created some challenges. But I want to highlight that we still have made progress over the past year in both Hep C and B. And Hep C, I'm going to focus on screening, diagnostics, and treatment, and spend most of my time there, and then finish with Hep B on some efforts in vaccination and treatment. So before I begin, I think it's important to recognize and to honor our three colleagues, Harvey Alter, Michael Houghton, and Charlie Rice, who had this monumental achievement this year of being awarded the Nobel Prize for their discovery of hepatitis C, and just remind ourselves that this really was the first step towards elimination. We couldn't be having the discussions we're having today until these scientific achievements were made, but it's also important that we remember as a group in this field that we use this opportunity where the world is focused on hepatitis C and remembering the importance of this discovery, and we use this to try to strengthen and push forward our elimination efforts. So again, congratulations to my friends and colleagues, and to all of us that we should use this as an opportunity. So let's look at some progress on the screening front, and I would highlight this recommendation by the U.S. Preventative Services Task Force, where they moved from the previous baby boomer or birth cohort recommendation to recommend a one-time screening of all adults between ages 18 and 79 for hepatitis C. And I think this is a very important recommendation. It recognizes the fact that we really have two epidemics, certainly in North America, of young people who inject drugs, and then of the older birth cohort or baby boomer population. Now, importantly, with baby boomer screening, it was effective, but perhaps not as effective as we had hoped. And clearly uptake in the way we promote this recommendation and get it taken up by primary care providers is going to be critical to its success. Fortunately, we saw a similar recommendation from the CDC with also recommending adult screening, but they went a step further and made sure to highlight that we screen pregnant women, and not just once, but in every pregnancy. And I think this was a very important recommendation that they made. It recognizes that for many people at high risk of hepatitis C, pregnancy may be their only contact with the healthcare system. It's really an opportune time to screen them for Hep C and get them linked to care. Now, we know that treatment right now is not possible during pregnancy, although this year was published the first study of treatment in the third trimester with good safety and efficacy. This certainly shouldn't be done yet outside of a clinical trial, but hopefully we'll see a move towards this that will both be safe and prevent vertical transmission of hepatitis C, which continues around the world. And I would just highlight an abstract that was presented at the liver meeting a few weeks ago, showing that unfortunately screening of children after they're born to a hepatitis C infected woman is still very poor. So we need to get better on that front. Now, I would highlight this output of the CHI Foundation, the Clinton Health Action Initiative, where they put out this hepatitis C market report. And this is a really useful document. If you haven't seen it, I would encourage you to take a look at it, which really is an overview of supply issues for both diagnostics and treatment focused on low and middle income countries. And they highlight some determinants, some benchmarks, and some minimization strategies for the costs of tests, both rapid diagnostic tests and PCR tests, as well as for the costs of treatment. And it's really quite useful. I'll show you some of the types of outputs. So this is an example looking at diagnostics, and what you see first on the right here are you see the variability in the price of a viral load or of a rapid diagnostic antibody test. And you can see in these low and middle income countries, high variability in the cost ranging from $19 to $70 for the same test, and similarly for a rapid diagnostic test from over $2 to down to 30 cents. Remarkable when you consider that these are identical tests. So what they highlight is the importance of price visibility. What's actually going into that price? It's not all the cost of the test. This is just looking at the GeneXpert real-time PCR test, which is a point-of-care PCR test. And you can see that about $15 of this $21 comes from the price of the cartridge, but then you see these additional costs, and these vary, and there may be some room for negotiation to try to bring down these prices and make this more affordable, especially in places where people pay out of pocket for these tests. In addition, we can try to make our diagnostics more efficient. So this was a study that I mentioned last year that's now been published, and it's some work from our group using the OraQuick rapid diagnostic test. And what we showed is that people who are viremic, who have a current active hepatitis C infection, will test positive on the OraQuick faster than people who are not viremic, who have cleared infection either from treatment or spontaneous clearance. And the important thing here is that of viremic individuals, everyone tested positive for an antibody within 5 minutes. That means that if someone's still not positive at 5 minutes, they may still test antibody positive, but they're not going to be viremic. And those people can be, they don't need to wait around for the end of the test. Similarly, if someone tests positive within 5 minutes or early, we don't need to wait 20 minutes to tell them the outcome of the test. So this, first of all, speeds up our throughput, particularly in high volume settings, but it also decreases the amount of expensive HCV RNA testing that's required. And I would encourage you to consider using this. Importantly, this has not been validated with other rapid diagnostic tests. Now, the CHI report also talks about treatment, and just like diagnostics, they show that there is wide variability in the cost of therapy. Here you see the range in price of 12 weeks of sofosbuvir and declatosphere, and you can see in low and middle income countries ranging from over $1,300 in Vietnam down to $28 for the same regimen in these different countries. And why is this? Again, they really encourage you to break down the cost. So it's not just the cost of the drug, but what they show is these different things that add up towards the total final price, and highlighting that these may be variable and they may be negotiable. And they really point out that there's very significant differences in the in-country price markup. So you can see here in Vietnam and Cambodia, neighboring countries, a 234% increase in the or markup in the price in Vietnam leads to a much higher price for the same treatment than in neighboring Cambodia, with only a 59% increase. So I think this is key, that if we understand why the costs are high, that's going to be the first step to bringing them down. And I applaud CHI for bringing all of these data to our attention. Now, they also advocate for a very simple approach to treatment. They say you should do a simple fibrosis assessment, take a medical history, including medications, and they say reserve genotyping for children where you might still use a genotype-specific regimen, although this is going to become less frequent as well. And they recommend no genotyping, no on-treatment HCV RNA measurement, no on-treatment monitoring in those without cirrhosis. So this is a nice, simple paradigm. Well, are there actually evidence to support this? The good thing is that there are. Indeed, from the recent AASLD liver meeting, we saw that this study, the so-called MIN-MON study, looked at evaluating people in both high and low and middle income countries with a very simple approach. So people had no pretreatment genotyping. They were given 84 tablets of sofosbuvir and velpatasvir. They had no scheduled on-treatment clinic visits or labs done, and they had remote contact at week 4 and 22. And what you see is that almost everyone followed up with their remote contact, so very good adherence to this protocol. And then impressively, almost all 400 people followed up for SVR12, and they achieved a 95% SVR12 result, which is what we'd like to see, but impressive data to support a simplified approach. We had previously done, but now published, this randomized trial evaluating a similar approach of a standard follow-up of monthly visits versus a simplified approach of no visits for glecaprevir, pibrentasvir, the other pangenotypic widely used regimen. And that you can see that in per protocol, people did identically well, very high SVR rates, a slight drop off with the simplified approach by intention to treat. And this really just highlights that for people where adherence may be a concern, this approach may not be optimal, but it really does work for most people. And I think gives us the evidence to back up what CHI and other guidelines are now recommending as simplified treatment strategies. And indeed, the AASLD guidelines, which were previously a 22-page document, shrunk to 1 page for simplified treatment and assessment last year. And you can see that for people without cirrhosis and no prior DAA treatment, they can have a very simplified approach to treatment. A simple fibrosis assessment using non-invasive tools, simple basic blood tests, rule out hepatitis B and HIV, look up drug interactions, and then treat with a pangenotypic regimen, so no genotyping required, minimal or no on-treatment follow-up required, and then a very simple follow-up for those at risk of ongoing infection. EASL goes even one step further, and you see again simplified treatment, no genotype or subtype, and a simple approach of Sofvel or glecaprevir probenecvir for 8 or 12 weeks. But they go even one step further and say that SVR12 is dispensable except in patients with high-risk behaviors and in patients at risk of reinfection. Now, I would specifically highlight that also it's important to confirm cure in those with advanced fibrosis. They do make that point in the document, but not in this particular recommendation. So this is nice to see that the guidelines are now in line with evidence supporting this simplified approach. And this really follows, was also supported by this study that was presented at the AASLD looking at, can you use SVR4 instead of SVR12? We know it's hard to bring people back 3 months after the end of treatment. And they show that SVR4 in dark blue versus SVR12 in light blue, really almost the same. But it's important to remember that if you have a 99% treatment success rate, then even before you start, you know that 99% of people don't really need that SVR12 because they're going to be cured. It does suggest that you can probably say any post-treatment time is a confirmation of cure is probably good enough. But the key point here is that you could probably follow EASL's guidelines and dispense with SVR12 confirmation, except in people with cirrhosis and those at risk of reinfection. And a nice study that came out earlier this year at EASL, I think gives us evidence for the concept of treatment as prevention, which is something we've been talking about for years, this idea that if you treat people and reduce transmission, there's a prevention benefit in addition to curing the individual. And this was a study from the Spanish prison system led by Joaquin Cabezas. And what they showed is they were already doing screening of pretty good screening back in 2015, but they introduced treatment in 2016 and scaled it up to almost everybody being treated by 2018. And what you see is that the prevalence quickly drops. And what's the real evidence of treatment as prevention is not only does the prevalence go down, but they see reduced incidence. So they're having this prevention benefit of preventing new infections by treating those who are already infected, and very high SVR rates, and actually led to a decreased mortality related to Hep C in a very short time frame. So very impressive data. And they followed it up with this modeling study, which showed that the benefits were not just in the prison system itself, but in fact, 90% of the prevention benefits from this strategy were actually seen outside of the prison population. And this is important both for modeling and making the case to policymakers, but also for data collection to make sure we capture this more indirect benefit of treatment as prevention. In addition to showing solid data, we always have to think about the costs. And I think this study from Jag Chatwal and his colleagues at Harvard looking at the cost and can we get, what's the price threshold at which treatment actually is not just cost effective, but cost saving. So cost effective, good value for your money. Cost saving, you actually get back the money you spent on treatment by saving in downstream costs. And what they showed is that in low and middle income and in high income countries, you can get to cost saving within as little as 5 years if you can get the price of DAAs down low enough. And what they show is that in low income countries, pretty low, $64, but I showed you that with the CHI report, some countries are well below that. High income countries higher. So clearly we still need some work to do to bring down the prices of these drugs. But the reality is we are in a scenario where we can get the prices down to actually make this cost saving. It's not all good news. This is data from our province in Ontario, Canada, where we looked at over almost 40,000 people. And what we found is that late diagnosis continues to be a problem with Hep C, with a significant proportion of people presenting within 6 months of either presenting with liver failure or liver cancer. And that really stayed flat over time. So we still need work to do on the screening front. And this is really critical if we're going to get these countries here shown for high income countries. These are data from Homi Razavi showing that most countries are still not on track for the 2030 elimination targets, but they do show that small changes can take a country that wasn't on track and put them on track. And what they showed in Sweden, removal of fibrosis restrictions, in Germany, introducing an active screening program, and in Canada, just getting better data, actually switched them from red to green. So we still have work to do, but some progress on this front. Finally, switching to Hep B, probably the most important thing this year was that Gavi, that supports childhood vaccination, supported introducing the birth dose in countries where it doesn't already exist. We know that only 43% of countries offer the birth dose universally. Sadly, Canada is not one of them. And in low-income countries, particularly sub-Saharan Africa, that's very low. But Gavi will fund 50 countries starting this year to cover the implementation costs of bringing in the birth dose. The countries will still cover the cost of the vaccine, which is fortunately pretty low. And then finally, on the Hep B front, there is progress moving towards cure. So we have very effective treatment that can suppress but rarely cure the virus. And I think there's excitement in this area, but I think it's important to remember this isn't as easy as Hep C. So be patient, but there's new therapies coming on a lot of different fronts. And I would hope within the next few years, we will have curative therapy for Hep B, which will be another game changer. So to summarize, despite COVID-19 and its many setbacks, there has been progress towards elimination this past year. In Hep C, new screening recommendations, diagnostic improvements, and some cost containment efforts, as well as the useful report from CHI, simplified treatment, both evidence for it and the guidelines supporting it, and on Hep B, rolling out the birth dose and moving towards curative therapy. Thank you very much for your attention.